Okay, so Barbara, welcome to Agreed Dementia. It's such an honor to have you, and we're so looking forward to your presentation.
Thank you so much. And I have to say the honor is mine. And I want to, first of all, thank Jamie for not only setting up this time to talk to you all, but also for the enormous amount of work she's done with us, and the contributions have been fantastic. So without further ado, I'm going to be talking today about the framework that we developed and a little bit of the history for return of individual research results, and talk as fast as I can. I grew up in New York, so I'll do my best so that we have plenty of time for discussion. And I want to say that, you know, everybody who works in their individual capacity, doesn't speak for their organization. I have no personal conflicts of interest, and we're supported by voluntary contributions and by grants. And again, thank you so much for having me. So I'll give you a bit of an introduction. I'm going to talk about the importance of returning results, the evolution of the work, the project update, sort of walk you through the website a bit so that you can understand where to find more detailed information, and then leave plenty of time for questions, because there is always great discussion that follows. So the MRCT Center is a research and policy center at the Brigham and Women's Hospital and Harvard that really looks at the conduct, ethics, oversight, and regulatory environment for clinical trials, usually multi-site and multinational clinical trials. And we do the work by pulling together stakeholders, academics, patient advocates, industry, nonprofits like the Gates, regulatory folks, and then whomever is relevant to the question that we're asking. And we don't really focus so much on defining in grim detail the challenges, but rather really work to find ethical and actionable and scalable solutions, figuring that if everyone's around the table when we discuss it, we're more likely than not to find solutions that work for all. And again, sorry, this is always a problem. So I'm going to first speak a little bit about aggregate return of results, you know, the plain language summaries of this trial, because I think one of the things that worries me is that while we can get deep into the weeds of individual results, people don't know what the results of the trial were in aggregate. I mean, we do such a bad job. And it really starts way before returning results at the planning stage, so that you anticipate returning aggregate and individual results at the beginning. Think through what results you're going to have, when they're going to be available, what the risks are, and validity is, and I'm going to get into all of this. But for aggregate results, for the results of the trial, that really occurs very much at the end of the trial, after the data is analyzed, collected, and there's a report and an understanding. So there, it's important to have plain language themselves. But it's really the expectation that of many documents that, you know, including the Declaration of Helsinki, that research participants should be given the option of being informed about the general outcome and results of the study. And we took that to heart, and in 2017, after about 2.5 years of work, came out with a principles document, a guidance document, a results toolkit, so that it's clear how to do this, and tried to give templates and neutral language. You know, you don't talk about non-inferiority. People don't understand what a non-inferiority trial is. Don't say that this is better than that, because only the regulatory agencies can say whether it's better or not, and useful checklists, etc. I really think that it's important that before we get into return of individual results, we commit to returning and making the general results available, which should be fair and balanced and not biased and not promotional. That is consistent with participant volunteers and what they want to know. 90% want to know their results. 98% of study staff would like to provide those results, so there's no conflict there. 91% of people have never heard back from the trialists or in general about their results, about the study itself. And we're losing our public, we're losing our committed folks because 70% would not participate in future trials if they didn't hear. And I do want to say that the EMA, the EU, has made a really significant stance in 2014, and it went into effect in January this year, that they required trial sponsors to submit a plain language summary understandable to reasonable persons for each clinical trial with pharmaceuticals into the EU database. There's a huge 80-page document saying, how do you do this? We worked with them on that. And I really think it's one of those things that, at least I'd like to see Agreed Dementia and us push for and try and get the, clinicaltrials.gov to advance a site where we could do that. And really think about how we could join forces to do that. But if you return aggregate research results, the first question that people ask is, well, what about me? How did I do in that trial? How did I do? Was I in group A or B? And as we think about that, it becomes much, much more complicated because there are results that you could return from the first screening discussion with a participant all the way to, exploratory results with blood that has been stored for 2 years after that person has left the clinical trial. So there's a lot of information that could be available and a real complexity about whether and when and how you should return. But again, just like aggregate results, this takes planning. And when we think about it, it's really thinking before you even get into the study, thinking through every piece of that study. What results are you going to possibly have? How reliable are they? What's the utility? And again, should we return them? So when I talk about IRR, individual results, research results, it's any test or data from a research study that's specific to the individual, study arm assignment, lab results, genetic sequencing data, others. It's not aggregate results, plain results, lay summary, plain language summaries. And, when we ask, research participants want to know and expect to receive both individual and aggregate results. The expectations about data transparency and ownership are evolving in society. And I think returning and planning to return individual research results anticipates and responds to those expectations. And the ethical principles in research should be applied to the return. But again, this is easy to state and complicated to effectuate. So when we think about what can be returned, I've mentioned aggregate research results. Then there's which arm was I on? Was I on arm A or B? Then thinking about routine clinical results performed in the course of research. Are they urgent? Is it a potassium of 7.2? Is it an unexpected large mass on a chest X-ray? Is it actionable? Is it, even if not clinically actionable, is it personally valuable to the person to know? And then are these results of no known implications and of uncertain significance? There are incidental findings discovered in the course of a clinical trial that can be potentially clinically significant or actionable or of uncertain significance. And then there are research results where we don't know, anything about how to interpret those results. Those are possibly of likely significance or uncertain significance, where we still don't know whether a certain genetic, let's say, sequence change has any significance at all. It could be of potential proprietary importance to the people doing the research itself. And a lot of genetic and genomic results fall into this. There are certain genetic results that are clear, genomic results that are clear, but many are not. And what do you do with all of that? And if you actually think about what's easiest to hardest and do it on a sort of scale, it in my opinion falls in this hierarchy. We did release in 2017 a set of principles, guidance, and toolkit about returning results to participants, individual results to participants. And from that, you know, we sort of thought about a few things. First of all, has the participant opted in to receive results? We don't want to force people to receive them, but they should, if you're going to offer them, they should have a choice. And that choice should be free and should not be, you know, sort of influenced particularly, because it's not, it's a lot of these results are tough. And people need to know and make a choice about whether they want to receive them. And then, are those results analytically valid? Do we know that they're right? Could they be repeatable? Are they performed, for instance, in a CLIA laboratory or in the same way that one would have done clinically? Or are they really research procedures and you need to think about redoing it in a way that is reliable? Does the result have clinical validity? Does it matter medically or clinically? Are the results urgent or actionable? And again, are those of personal utility? And, you know, for individual return of results, does sharing the results impact the integrity of the study? If you return in the middle of the study, is that going to influence the outcome of the participants' experience or the results of the study itself? And then, of course, does it comply with institutional policy, laws, and regulations? So there are a lot of challenges, and those emerged over the 3 or 4 years since we did that initial piece of work. A high barrier to entry. There was concerns about liability and fear of the unknown. If we return them, are we liable for them? Must we provide follow-up? If we return some genetic studies, must we return all genetic studies? Is there a duty to hunt? There's an unclear differentiation of responsibilities between and among stakeholders. Is it the sponsor's responsibility? Is it the investigator's responsibility? Is it the primary care provider that should be engaging with the patient or participant? Because after all, that's going to be who they're speaking to thereafter. And in the absence of regulatory requirements or guidance on what to return, when, and how, it's really hard to get buy-in throughout the organization. It's a huge uncertain territory. So when we did the version 2, and which is what Jamie contributed to and others, we started with getting guidance on starting with a plan for gradual progression, so you'd get used to returning it, figure out what you can and cannot do, a roadmap to clarify the stakeholder roles and responsibilities, a reclass of the results type, which we had done in 2017, which we needed to remodel, and then how to create a return of results plan, specific tools, and again, then topics of continuing complexity. And the folks who really worked on this are listed here. And they stretched from folks that we know that worked with us at the MRCT Center, a number of investigators, a number of patient and patient advocates, a number of human research protections programs, some professionals, some individuals that were in pharmaceutical companies that were very familiar with the challenges. And we released this in March of this year. So if you think about the intended audience, there's research sponsors, those developing the treatments and financing the clinical trials, the HRPPs, the Human Research Protection Programs, and the IRBs, who really have oversight responsibility and must ensure that we are protecting the welfare of the individuals, the study staff and investigators, and then importantly, the patients and participants, so that they know what their rights are, they know what questions to ask, they know how to approach this and to think about it. So here's the website. I'm going to go through it a little bit so you can see where it and how to walk around it. We put a fair amount of thought into trying to sort of make it a home so that people can find what they need and explore it. So we start with where to get started, how and why to get started, and think about, you know, sort of designing a pilot, who to involve, the methods, finding a policy for that, and then suggested a proposed progression that obviously we're starting with return of aggregate results, but you should be prepared to return urgent findings. You must return is in a clinically significant way urgent findings. Study arm assignment, primary outcomes. Secondary outcomes are more complicated because, of course, secondary outcomes include sometimes up to 30 different results. And are you going to be selective about those? Are you going to choose which ones you're going to give as results? And is that going to be a fair representation of the trial? And of course, routine results, I should have mentioned. Those routine results, you know, complex, but are they done in a clinically reliable way? Then thinking about how to return results, there are stakeholder roadmaps determining what to return, how to return, including who, what, when, where, and how, and then giving you some result-specific guidance. So that looks like, you know, urgent, as I mentioned, actionable, personally valuable, and no known implications. And, you know, this is where I think things get incredibly complex pretty quickly. And I'd love to have some discussion about that at the end. And particularly in an evolving disorder like, you know, dementia, there's a real sort of need to think through what's actionable, what's personally valuable, how does that intersect, and what will the participants do with the information, or their carers do with the information, and what responsibility do we have for that? So again, we start with the steps in a clinical trial, which I've mentioned, and then think about the types of data that might be generated in the trial so that it's very clear what you're deriving in that trial and will have access to. Classification of the results in terms of urgent, actionable, etc. And then thinking about a roadmap for each stakeholder, which provides a basic overview of each role and responsibility, and then has individual guidance or tools related to each responsibility and task. So you're looking at this page, which starts with preparation for the study, on study, and then end of study. And then for each of them, thinking about some of the different issues behind what you need to think about for at each step. And each of these, you know, you can click on and see greater results and greater guidance. So there's a time period and then the responsibilities, and tasks, and those are organized based on the different pieces of it. And again, thinking about how to return, of course, the data holder, either the PI or the institution or the sponsor, could return it directly to the participant. A little complicated when the sponsor is a pharmaceutical company, but so that is becoming more frequent, and through private websites with controlled access. Of course, it could go through the healthcare provider who will have a relationship with the participant. It could go through a website portal, which people would have access to. And I think each of these have their benefit and challenges. You know, a website does not provide this kind of personal contact that people have and may need. And one needs to sort of double down on each of these, thinking about what's included, what's necessary. And for instance, the website portal, how do we supplement that with the kind of support that people might need? So we talk about who, when, what, and how, and the choice, and how to prepare people to have a choice as to whether they wish to receive it. And again, for each of those, we go through the different kinds of recommendations and the who should give them and what the constraints are around providing them. So we separate this guidance based on results type, and as you can see, it's starting to become a rather complex Mobius strip, but once you're familiar with it, it starts to make sense. And then thinking about different data types, there's definitions, examples of each of them, links to basic considerations like who, what, where, and how, the informed consent guidance, like what should you say, what could you say, what should you think about in terms of the constraints of what you want to promise versus suggest versus say you're not going to do. I think that if you know that you're not going to return results, you should say that. You should tell people you're not going to return results. And I think you should explain it. If you are going to return results, that's fine, but you should make sure that you tell people that at the moment where you're going to have the choice to return them, we will ask you. It doesn't mean that we have something of significance. We need to know at the time whether you want to hear it. If you know that you may have urgent results and it's not a choice as to whether to communicate them, that's again something that I think should be communicated. And if that's the case, and you're going to need a the provider for the patient or participant, they should be preparing to give you that information. So we need to make sure that we have the expertise to respond to those results or advise in other capacities. And then finally, we have tools and templates, resources, links to the guidance documents, and case studies. And these are the kinds of tools that we have. We wanted to do our best to try and think about those things where people would struggle with it and provide an adaptable tool so that people weren't trying to create a new wheel where there was a wheel already in motion. Nothing is required about using these. We just try to do whatever we can to make the administrative burden and the sort of cost of doing something, costs emotionally, physically, time, try to decrease that. So, and then we have a significant section on resources for participants, which I have to say, Jamie was instrumental in making sure that we thought about comprehensively, deciding whether or not to receive the results, considering genetic results, and then equipping people with a list of questions that they could ask if they wanted to ask, and really trying to strengthen the resolve and empower the participants to be their advocate for understanding and getting results and understanding what the limits and possibilities are. So we are going to come back with further review of returning genetic information, some guidance for biobanks, because some samples are identifiable and will have results, returning results to parents, guardians, and representatives, which are very different concerns than we're talking about today, and then additional case studies as they evolve. And with that, there's the result, and I hope I left some time for Jamie to follow and for us to have a discussion. So, Jamie.
Oh my goodness, Barbara. Your work, oh, let me put my video back on, sorry. I just want to say how honored and empowered you have helped me and other research participants, that you really took our voice in creating these tools, and I hear our voice threaded all through it. And I'm just excited about it. I can't stop talking about it. And thank you so much for honoring our voice. It's amazing.
Well,
and a lot of hard work.
You made this real. So you and the group that worked together. Thank you.
Yeah,
So
I
I
have to
flew
say-
through that in order to leave some time for discussion.
Yes, yes. So I think what's beautiful about it is it's filled with structural solutions to all the questions. I mean, so we know about, for example, incidental findings, that it really should be in our consent forms, but the way you framed this in terms of what's important for the participant is just amazing. So for example, at least getting a release of information. If you don't plan to share urgent results, you should get a release of information for the clinician so that you can have them integrate it with their care. So very concrete guidance. It was just beautiful. I think incorporating cognitive dysfunction into this, that's something where this group can be very helpful. But Jamie, do you want to moderate questions, or do you want me to? Because I mean, again, thank you so much for bringing this together. I just, there's so much good stuff there.
I think please go ahead and moderate, and
Okay.
and I look forward to listening. So
Okay, so just a lot of thank you, wonderful that I'm hearing. Does anybody have any questions or comments about this that you would like to say out loud? You can unmute yourself.
I do have a question, but I'm hoping Dr. Hewling Hummel will pipe up. She's written some things in the chat, but did you want to say something?
Yes, please.
Hi, everybody. I'm on jet lag, and I just wanted to thank the presenters so much for just kind of pushing this forward. I've been in ADNI for 12 years and have been begging for any results. And it's, I think it's time. And I'm thank you, Jamie, for all you did to bring our voice to the table. And I think that this is a great step in moving forward in terms of sharing results with those who wish to receive them.
Yeah,
You know,
absolutely.
and one of the things that I'm sensitive to is that the new regulations, the common rule, say that you must decide and put into the consent document whether you're going to return results or not. And you know, I argued with OHRP a fair amount about this, because I think that the easier course of action is for people to say, no, I'm not going to return. And I think that it sort of nudges in the wrong direction. So I lost that battle, as I lose many of my battles, but you know, I think we have to continue to keep up the good fight.
One thing, big point of news, is that ADNI is releasing to everyone their amyloid PET, regardless of status.
It's optional, but
Oh, is
yeah,
it?
but they are
Mhm.
building it in, yeah, regardless of cognitive status.
Mm. Do you
Yes,
know how that's going to be done?
it's going to be done very carefully, and there will be, training for the disclosure for each of the PIs. So, leveraging our experience with the A4 study and other studies where people with no symptoms are being told their amyloid status. So yeah, it'll be done very carefully, and we will be studying the impact it has, and also the impact it has, hopefully, in bringing in a much more diverse group of participants into these longitudinal studies. We know that many clinical trials now are offering this information, and a big longitudinal study like ADNI is really in direct competition with studies that are offering potential benefit with an intervention. So I think that was one of the drivers, but the other driver really was the voices of the participants who are asking for more of their individual results. Since I interrupted you there, Allison, I wonder if I could just go ahead with a question for Barbara. We are struggling in this field in Alzheimer's, where the disease has always been characterized by people who now we see have late stages of disease and is building for many years in advance of that. But the prediction of risk is still uncertain, and that impacts our ability or our willingness to share what we're seeing as risk information. So for example, a plasma test can now be used to estimate risk enough to define a study population, but not enough to tell somebody that you have elevated risk for dementia later down the road, or with any certain, even if we could say that with any certainty of when that would happen. So that really affects researchers' ability to share those individual research results, which is what people want. I chair our advisory board for clinical trials, and they say they want anything we have, and that they're okay with uncertainty. And I'm just wondering, Barbara, because you work across diseases, are there lessons that we can learn in Alzheimer's from other areas, other diseases like cancer or genetic diseases, where they're sharing this risk information in a way that's helpful to participants but not harmful?
Such a great question. And let me say that, I'll tell you another battle I lost, since we're now disclosing that. I really feel like we had an opportunity in a study like All of Us to learn a lot about how people want to receive information, whether they want to receive it, why they do or don't. And that it would have been a perfect time to build into such a sort of a comprehensive study and longitudinal study and diverse study to learn about this. And I think each of these things are basically not in a cold way, but are research questions. We don't know. We don't know whether people say it before they know and then wish that they could, put the toothpaste back in the tube, or unring the bell or whatever. But on the other hand, I think personally that it is the individual's right to choose. And if they want to know that we need, unless there's a real reason not to share those results, we should be prepared to do that. And we should be prepared to do it with the time to explain and to support and to make sure that there's a window or a way of providing ongoing support, because people will come back 2 years later and say, I forgot my keys last night. I wonder, can you do another PET? And I just, I think we've got to be prepared for what this means. But on the other hand, it is how we're going to learn. It is how people will become their best advocates for their health. And I am not a particularly parentalist person. I believe that in the ability of everyone to understand if we spend the time helping them to understand. Maybe that's a little Pollyannish, but, and one of the things we don't have is enough people to interpret and to be that sort of, doula for return of results.
Right.
Um,
Barbara, this is
and
Neelam. When you talk about
Yeah.
doula, what you're saying here, I keep thinking all the terrific work you've done. Have you brought in the MDs? Because we're not in an island with this, okay? So we return results in research, and then our participant is somebody else's patient, whether they want to be that or not. They then go to the MD, and the MD's like, what? Like,
Yeah.
they said this, or have you started to do a little bit
Yes.
of that work? And if you can just tell
Yes.
the group about how that,
Sure.
that
So
has
one of
worked.
the, and it's another thing that I am very hopeful as we evolve how we are doing clinical trials to be more decentralized and think about bringing the trial to the patient rather than the patient to the academic medical center, that we have done a very poor job over time of involving the healthcare provider in the work. Take the cancer patient. They get referred for a clinical trial, something happens, and at the end of 7 months, we either send them back or we keep them. And we never really engage the healthcare provider who has the relationship with the person. So this is an organizational change that we need to undertake, where we need to bring in the healthcare provider earlier, equip them with the information so they're not sort of there having to defend some knowledge base or lack thereof. And they don't have the tools to do that.
And they
Now,
don't
all of-
refer, Barb. They don't
and-
refer either, right? It goes the
And they
other
won't
way.
refer. if
Exactly. They're not going to
if-
refer. Absolutely
Right.
not. Yeah.
Right.
Yeah.
So what we did a study some time ago to reach out to a number of healthcare providers, both who had patients that they had referred, people that had chosen not to. And, the main reason was this sort of informational silo or inability to bridge that information gap. I will say that, we have to be respectful of the time that this takes. And healthcare providers are already stressed in terms of the amount of time they spend. And then you ask them to do something that they're not comfortable with, that is going to take extra time. And again, really problematic. As you can see, I can talk for hours.
So Nina, I know you have to leave the call, but did you want to ask your question and we'll record the answer?
Thank you. Well, I don't think we've met, Barbara. I'm Nina Silverberg, the director of the Alzheimer's Centers at NIA. And because each of the Alzheimer's centers has a neuropathology core, we have had a lot of questions coming out about consent and what information gets shared with families, and whether the samples and or data could be used by pharma, and how to help people understand the meaning of that. And so there's really a lot of ethical questions around these issues, and I would love to hear what your future plans are around that topic. But I do need to go. But thank you for a fantastic presentation.
Thank you. And I will say that I think these are all issues that need to be unpacked. And there's no, just for the recording's sake, I guess, there's no, I'm also very careful about generalizing. When you speak about, a population that has cancer, very different than a population that has or is likely to have dementia. So I think we have to be careful about how we generalize. And you can see it in every aspect of the work we do, that there is learning to be done, not only about different people their culture, their background, their education, their understanding, and their desires and sort of agency, but also about what that result will mean to them.
Yeah.
You know, so.
I think there's definitely a parameter space here that needs to be better understood. Are there other questions? I see some videos on. If there, I know we can go for a little longer. If there's something, and Barbara, you know, again, I hope that we can work together on some of these issues. I think Nina raised an important point, and you know, what you've accomplished is amazing. It's a tremendous resource for us all. Any other questions? We're at time, but well, okay.
Good. Well, and
thank
I
you
look
so much.
forward to talking further. Really amazing group of folks. I will disclose that, you know, my mom had Alzheimer's for 19 years. So I am well familiar with this. And my son wants me to get an ApoE4 just because he's convinced every time I forget something that this is the beginning of the end. So I am well familiar with the work that you do.
Oh, you could be
and
an
I want to appreciate
absent-minded
it.
professor too. That's
So, but thank you so much for everything you do for the community as well.
Thank you,
Thank you,
Barbara.
Barbara.
Thank you.
Thank
Thank you.
you.
Bye.
Bye.